everyone. I am Dr. Rashmi Roy, and the Senior Thyroid Surgeon at the Hospital for Endocrine Surgery. You can see the Hospital for Endocrine Surgery behind me. We are here in Tampa, Florida, and I only perform thyroid surgery here at the hospital. I'm probably one of the highest volume thyroid surgeons in the country. I perform over 600 thyroid surgeries a year. And our hospital is very special. It's one of its only kind in the country where we only perform endocrine surgery. We are a destination hospital where 50% of our patients are out of state, 10% are international, and we streamline the whole process for all of those patients so that we can make this as easy of an experience for everyone. So thank you for joining me. Today's going to be really fun. I'm just going to be answering live questions from you guys, and I hope that it's super helpful. And I guess we'll get started with the first question. So, how can I have thyroid cancer if my blood work is normal? So I get asked this question all the time, and people just can't understand how their thyroid cancer wasn't detected in lab work. And the fact of the matter is that thyroid cancer doesn't show up in blood work. And in fact, some thyroid cancers and most thyroid cancers don't even have any symptoms. So the way that thyroid cancer is really found is incidentally, either you feel a lump on your neck, or a doctor has felt a lump on your neck, or you get a scan performed for some other reason that identifies a thyroid nodule, and then that starts the workup of an ultrasound or biopsy. But don't be fooled that if your thyroid function in your standard lab work is normal, that there's no way that you can have thyroid cancer, because that's absolutely not true. So I actually think everyone should get an ultrasound, especially women at the age of 35, just kind of a screening ultrasound to see what's going on with your thyroid. Thyroid cancer affects women 3 times more than men. So I think that, all women at that age should get a thyroid ultrasound, because really, if it doesn't show up in blood work and it doesn't have symptoms, how are we going to find it? So the next question is, I had half my thyroid removed and pathology showed follicular thyroid cancer. I went back in to have the other half removed, and that side's pathology showed papillary thyroid cancer. How is it possible for a person to get 2 different types of thyroid cancer? And then there's a second part to that question. So it is possible, and it happens. I mean, you can have, even if the whole thyroid is taken out, the final pathology can come back with a follicular thyroid cancer on one side and a micropapillary thyroid cancer on the other side. Or if you have medullary thyroid cancer, we're removing your whole thyroid gland, the lymph nodes behind the thyroid gland, and a small papillary thyroid cancer comes up. So it's possible, we don't necessarily know why it happens. It doesn't mean that you have more of an aggressive thyroid cancer if you have 2 thyroid cancers in the thyroid gland, but it certainly, can happen. The second part of the question is, I'm being recommended for radioactive iodine next. Do you think that's a good idea? So radioactive iodine treatment after thyroid surgery is indicated in certain cases. I do not think that it should be a knee-jerk reaction, that just because you have thyroid cancer, you need your whole thyroid removed and you need radioactive iodine treatment. There are certain indications to have radioactive iodine treatment. One of those is that if we're talking about a papillary thyroid cancer, if you have significant lymph nodes involved, significant lymph node involvement, invasion into surrounding musculature, invasion into soft tissue, those are reasons to get postoperative radioactive iodine treatment. If we're talking about a follicular thyroid cancer or a hethal cell cancer, and there is extensive vascular involvement of the thyroid cancer, then that's an indication for radioactive iodine. But if we're just talking about a small thyroid cancer, there's no lymph node involvement, it's completely contained within the thyroid, there's no reason to have radioactive iodine in those cases. And in fact, we can cure you here at the Hospital for Endocrine Surgery by potentially just taking out half your thyroid. So you can even save the other side of your thyroid gland and maybe not even need thyroid hormone medication. So just look into your pathology, ask questions. Don't just think that you automatically need radioactive iodine treatment just because you have thyroid cancer. Next question. Is it possible to remove only the nodule and not part of the thyroid? So I get asked this question all the time as well. A lot of patients, they just want to know, can you just remove the nodule? I want to save as much of my thyroid as possible. I don't want to be on thyroid medication. So is it possible to just remove the nodule? Yes, it's possible. I can just take out the nodule. Is it a good idea? No, it's not a good idea. And the reason why it's not a good idea is because the majority, thyroid nodules, if we're talking about thyroid surgery, we're talking about a potential for thyroid cancer. So removing a thyroid nodule only is not a cancer-appropriate operation. It's not going to cure your thyroid surgery. So if you just remove the nodule and you have thyroid cancer in that nodule, we are now talking about setting you up for a second surgery, which is never a good idea to set someone up for a second surgery. So you never want to do an operation that's not going to be a definitive or curative surgery. So it is possible, but I don't recommend it. Here at the House of Endocrine Surgery, we want to do our best to do the most minimal operation that we can, but still curing any potential thyroid cancer. So that would be removal of half your thyroid. And 50% of patients with half their thyroid don't need medication. So that's our goal. We want to save as much of your thyroid as possible, but we also want to do the right thing. So I hope that answered that question. Can a goiter affect your hearing? So no, thyroid goiter cannot affect your hearing. There are instances where a goiter or a large thyroid nodule or a thyroid cancer can cause some ringing or even a little bit of pain in the ear, but it's not going to decrease your ability to hear. And the reason for that is a little bit complicated. The nerves in the head and neck area are very intermingled. So it can cause radiating pain, sometimes, rarely, but sometimes you can have kind of a ringing sensation in the ear. But those symptoms are really not common at all, but it definitely will not affect your hearing. Next question. Do you think if I were to take iodine, say from a drugstore, it might help my thyroid problem? Or is it too late since I already have Hashimoto's? So iodine is a problem with thyroid goiters. But that's really not in America. So that is in third world country, underdeveloped countries where there's not enough iodine in the normal diet. And so in those places, you have more incidences of thyroid goiters. But even if you're not adding salt in America with an American diet, you're not adding salt, you're having a low salt diet, no salt added diet, that's not going to cause any thyroid goiter issues. And so taking iodine, also, if you're taking extra iodine, that's really not going to help anything. So really these alternative methods of treating thyroid nodules, it may help in your diet or how you feel, but it's really not going to affect the actual disease process. One thing I should mention, even though it's not really related to this question, but patients with Hashimoto's, the best diet for Hashimoto's is actually a gluten-free diet. So gluten is very well known to affect Hashimoto's patients. So if you're going to be changing anything in your lifestyle with Hashimoto's, a gluten-free diet is actually the best diet to follow. It's very difficult to do, but it's the most effective. Next question. How do I know if surgery is necessary to remove my thyroid nodules? I've been told to monitor them for years and years. So, thyroid nodules are very common. As we get older, we have thyroid nodules. Most thyroid nodules are benign, but, it's true. How do you know when to act on these nodules? So there's different indications for thyroid surgery. One is if the nodule is suspicious for thyroid cancer. So how do you know that? You know that by ultrasound findings. Does it look suspicious on ultrasound with microcalcification, irregular borders? Does it have vascularity to it? Things like that. So those are things that make a nodule suspicious on ultrasound that would then prompt a biopsy. If a biopsy is atypical or suspicious, that warrants an operation. So, one indication to have thyroid surgery is if it looks suspicious on ultrasound or if it is suspicious on a biopsy. The second is it causing you symptoms? So you can have benign nodules, but they're big, or the placement of the nodule is causing you symptoms, meaning having trouble swallowing. It can give you a chronic cough when you're not sick. You may feel like you constantly need to clear your throat. That's a very common symptom, and it's a vague symptom that people don't often associate with a thyroid nodule. Obviously, the more obvious ones, difficulty breathing, if you can see it. There's a textbook sign if you raise your arms above your head, and that causes difficulty breathing. So things like that. So if you have these compressive symptoms, that's an indication for having surgery. So those are the main ones. Obviously, some other ones are if you have something called a hot nodule or it's hyperfunctioning and it's causing too much thyroid hormone, that's another reason to no longer monitor your nodule, but that you need surgery. So you really need to have an expert endocrinologist, an expert doctor following you so that you're not just prolonging, the monitoring of these nodules. There are many times I see patients that, they have these huge goiters and they've had them for 15 years and their doctors were just telling them to monitor because they're not causing problems. Well, there's a point where monitoring should stop and where surgery is really the better option. Next question. Could thyroid cancer affect my ability to have children? Is the treatment plan any different for women in childbearing years? So again, a very common question. So I'm glad that you asked this. So thyroid cancer is not going to affect your ability to have children. Removal of your thyroid gland is not going to affect your ability to have children. What would affect it is if your thyroid function was not normal. So after thyroid removal, you need to make sure that your thyroid function is within normal limits and that you're feeling well. So if I'm removing your whole thyroid gland, I'm starting on full dose thyroid hormone replacement the day afterwards. You're going to get blood work checked 4 to 6 weeks after surgery. That's going to determine where you are in the thyroid function range. And you need to be a little bit of an advocate for yourself because the thyroid function range is a large one. So you don't always want to go by numbers. You also want to go with how you're feeling. So you need your symptoms to match your numbers. And then you know that you're on a good dose for your thyroid hormone. And as long as that remains to be that way, then you should have no issues with having children. So the treatment plan, the only thing that would differ is if radioactive iodine is indicated for thyroid cancer, obviously we would postpone any radioactive iodine treatment. And there's no, real time limit on when to get radioactive iodine treatment. So let's say you have a thyroid cancer that's involving lymph nodes in the sides of your neck. You needed your thyroid removed, a neck dissection, things like that, where radioactive iodine would be indicated. We would just say, you had your surgery, go ahead and, try to have a baby, have the baby. You can even breastfeed. You can have the radioactive iodine afterwards. So there's no real time limit on when to get it. So that would be the only way that the treatment plan would really differ is if radioactive iodine was indicated. Okay. Are certain types of thyroid cancers more likely to be hereditary than others? So the well-known hereditary thyroid cancer that runs in families is medullary thyroid cancer. So medullary thyroid cancer is is a more aggressive thyroid cancer than the standard papillary thyroid cancer. Medullary thyroid cancers can be sporadic, meaning that you just got it because you did. And the other type of medullary thyroid cancer is hereditary medullary thyroid cancer, and those are ones that have a genetic mutation that can run in families. So if you have medullary thyroid cancer, you need to get genetically tested for the RET gene, RET. And if you are positive, then 50% of your immediate family members are at risk. So those family members need to get tested as well, and that goes for their immediate family members as well. So that is the well-known one that is hereditary. Papillary thyroid cancers, we've seen families that have a strong family history of papillary thyroid cancer a mother had it, a grandmother had it, an aunt had it. And so we know that papillary thyroid cancer can have a strong family history. There is no known genetic mutation yet for papillary thyroid cancer, but I'm sure in the next coming years with more of our genetic work, we'll be able to find that gene, but we're just not there yet for papillary. I've had trouble with scar healing in the past and I'm really concerned about a big scar on my neck. Is there anything that can be done to minimize this? So I actually did a video about this on my YouTube channel. You can actually find it on exactly how to minimize the incisions that I make for thyroid surgery that we make here at the Hospital for Endocrine Surgery. So it's really an art. And so number one, it is, if you look on the internet, it's not this ear to ear scar that people do anymore for thyroid surgery. We want to make an incision that is cosmetically acceptable to you that will eventually, essentially just fade away. So we make the smallest incision that we can for your thyroid surgery. We design it in right above your collarbone in a natural skin line that you have or parallel to it. We do a plastic surgery closure. We pay a lot of attention to it because we know that that's all that you see. So you can actually find the video on my YouTube channel. I actually show pictures of immediately postoperatively, a month postoperatively, and 3 months postoperatively, and you could see how it really fades away. There are other tips that we give you on the discharge instructions so we put a glue on your incision. That's really all that you see. All the stitches are on the inside. The glue falls off after 3 weeks. And after that, you can use these silicone strips. They're called scar away strips. And those are the ones that we just recommend. But there's other things out there like Mederma or vitamin E oil you can choose to really kind of help with the healing process. But really, the scar should not be a deterrent to thyroid surgery or to make you scared or to procrastinate, the need for you to have surgery. Are there any other treatment options for thyroid cancer other than surgery? Is there any risk in waiting for surgery? Like, could it spread? So there is really no other treatment other than surgery for thyroid cancer. There are some institutes that have observational studies where they monitor small cancers. We get contacted by those patients a lot, and basically what has happened is that their cancer has spread, and now what should have been a small operation is now a big operation. So that kind of answers the second part of the question, is that if you wait, yes, the thyroid cancer will spread. It will spread to the lymph nodes underneath your thyroid gland, potentially to the lymph nodes in the side of your neck. The same motto that goes for every other cancer: early detection, early cure. So that means treatment, and so that's surgery. And so, if we find it early, if we treat it early, it's the most minimal operation. Like I said, even possibly only half your thyroid to cure your thyroid cancer. Next question. What will my life be like after I have my thyroid removed? Will I have lingering problems? So this is all we do, right? We take patients' thyroids out all day, every day, half your thyroid, your whole thyroid. And, like we said, the patients that have their whole thyroid removed, they need full dose thyroid hormone replacement. We don't expect you to miss a step. You will have your blood work checked. You may need a little bit of tweaks for the first couple months, kind of adjusting your thyroid medication. But we expect you to be the same person you are right now as you are after the surgery. You just need to take that pill every day. It is an art form. You need a good endocrinologist or a good primary care doctor who can manage your thyroid hormone. You hear Synthroid and levothyroxine. That's not the only medication. 95% of patients do really well on Synthroid. The 5% of patients that don't, there are other medications. There's Armour Thyroid, there's Tirosint, there's a combination therapy. So there's not just, if you don't do well on Synthroid, it's not like your life's over. There's other things that you can try. And once you get that thyroid medication and that thyroid dose, you should really feel well. A lot of people are scared to be on medication every day, but it's really not that difficult to do, you take it first thing in the morning. You don't need to drink 45 minutes later, and then you just start your normal routine. So you should feel really well on your medication. Can a goiter become cancerous? My endocrinologist said not to worry about that. So this is a myth. I did a video about this as well on my channel, as myths about goiters is I think what it was titled. And so it is true that 95% of thyroid nodules are benign, but that is not always the case. So you can definitely have thyroid cancer within your goiter. You can have benign nodules, you can have cancerous nodules. It's, for the most part, they're benign, but it's not always the case. So we do an operation that is cancer appropriate, so that we want to cure any potential thyroid cancer. So whether that means taking out your whole thyroid and the lymph nodes underneath, or just half your thyroid and the lymph nodes underneath, we want to do a procedure where when we get your final pathology a week later on your thyroid, we know that we've done the definitive operation and that you're not going to need a second one. So if your goiter is just on the right side, it'll be a right-sided operation. The lymph nodes will be tested. We'll make sure those lymph nodes are okay, so that if the thyroid is a cancer, you're cured. So usually they're benign, but it can be cancerous, so make sure you're seeing an expert surgeon. Next question. Can medication treat a thyroid goiter? So this is also in that video of myths of thyroid goiters. So guys, there's no medication to treat your goiter. There are no creams. There's no turmeric that you can take. There's nothing that's going to cure or get rid of your thyroid goiter other than surgery. There are, if you have a smaller nodule, there are things like radiofrequency ablation that could essentially shrink a smaller nodule. But if you have this large goiter, the only thing that is going to get rid of it is surgery. So don't be fooled. Don't waste time. Don't let this goiter grow down into your chest, make the surgery more difficult. Just don't procrastinate. Go to an expert. Come see us. Contact us. We'll be able to take care of it. Next question. How often should I have follow-up appointments to monitor my goiter and nodules? So, we've gone over the indications for thyroid surgery. If you have a goiter, you can have small nodules, and that's still called a multinodal goiter. It doesn't mean that you have this, big bad thyroid that needs to come out right away. If you have nodules and they're benign and they're smaller nodules and you're not having symptoms, absolutely, you can monitor them. And so I would recommend, monitoring your thyroid with an ultrasound every year. And, if the nodules look the same, you don't need to repeat any biopsies. But if there are any changes in a nodule, such as before, it didn't look suspicious, but now it has some suspicious characteristics, I would rebiopsy that specific nodule just to make sure that there's nothing kind of brewing within it. Lab work, if you have normal thyroid lab work, I would just do it yearly. So every year, get an ultrasound, get blood work, make sure nothing's changing, pay attention to your symptoms. As long as you're not having symptoms, it's not growing bigger, you could certainly monitor your goiter. Next. I'm having a lot of trouble with my thyroid. How can I get in touch with you? How long does it take to be seen by you? So, it's very easy to get in touch with us. All you need to do is to go to our website. Thyroidcancer.com is the website. There will be a tab there that says Become a New Patient. You click on that tab. I actually have a kind of step-by-step video. If you want me to walk you through it, you can find it on my YouTube channel. I'm basically at the computer kind of clicking you through how to become a patient. So you can find that. But thyroidcancer.com, go to the Become a New Patient tab, click on it. You'll fill out the form. You click Submit, and then you are going to get a call from one of us, one of the surgeons. So we're actually going to call you and go over your ultrasound, your biopsies, your lab work. So all of the workup that you have had done, we're going to go over with you. We'll let you know, what you need. You'll come in for an evaluation. If you're out of state or international and I decide that you need an operation, again, we'll do the evaluation in the morning. The surgery will be that afternoon. So super easy to contact us and to become a patient. We're booking about 4 weeks out right now, so it's not too long of a wait at all. So if you need us, then please go to our website. Next question. Can you walk us through what happens during the consultation? Are you able to determine during the phone call whether or not I'm a candidate for surgery before I travel there? So this actually kind of goes with the last question. And yes, depending on what you've had done, whether it's an ultrasound or biopsy or CT scan, absolutely, I'll be able to let you know if you're out of state and, if you need to fly here to come in. If you're in Florida, you can just come in for an evaluation. We'll do your whole evaluation here. So to answer the first part of the question, we do a full ultrasound. So this will be the most thorough ultrasound that you've really ever gotten. I can promise you that. We look at your whole thyroid gland. We look at all the lymph nodes on the sides of your neck and the center of the neck. If you need a biopsy of anything, a thyroid nodule or a lymph node, we do it right then and there. We have a pathologist there with us at the bedside. We will either give you the results later that day, or we'll call you the next day and we'll let you know what it shows so that we know exactly what we're dealing with. So during your consultation, we'll do that full evaluation. We'll do a biopsy at that time. We'll take a look at your vocal cords with a small camera. It's called a laryngoscopy. It takes about 30 seconds. We'll do blood work. So it's essentially a full thyroid evaluation so that we can figure out exactly what's going on with you. Next question. I had surgery to remove a nodule in December. My question is, how long does that sensation of having a lump last? And how long until the scar tissue gets better? So we get asked this question a lot. So recovery is a process, right? Thyroid surgery, it's a quick acute recovery. You're eating, you're talking, you're walking, you're caring for yourself right after surgery. We expect you to be up and, doing everything normally for yourself essentially that afternoon. There's no restrictions on diet. You can resume light cardio about 48 hours after surgery. But the recovery process with the soft tissue in your neck, that takes time. So that, that trouble swallowing or that lump sensation, that can last several weeks. It can even last several months. You can feel tightness in your neck for months after surgery. The way to help that process is really with warm compresses and massage. It's really not uncomfortable, that scar tissue, but for it to kind of get back to feeling normal, fully normal, it can take some time. So just kind of be patient with it. It's certainly, not uncomfortable by any means, but warm compresses, massage, things like that can help that process. Can hethal cells be released or spread from the thyroid when a lobectomy is performed? So a lot of patients are worried about this concept of seeding thyroid cancer. When we do thyroid surgery, we, do a definitive operation. So when we're talking about hethal cells, or really any type of a thyroid cancer, so we're talking about hethal cells within that thyroid nodule. So what you never want a surgeon to do is to cut through that nodule. If we cut through that nodule, then absolutely those hethal cells can be kind of expelled out. And so if that happens with a hethal cell neoplasm, where we're worried about a hethal cell cancer, that can be very bad. And that is when you have not had a good operation. And when you don't have a good operation for potential hethal cell cancer, you really can't be cured again. You're going to have to need repeat surgeries because that surgeon has cut through that nodule and spread these hethal cancer cells. But if you have an appropriate operation and the correct operation by an expert surgeon, you're having that thyroid lobe removed with good margins. So you're getting around that whole tumor. So in that way, you're not going to have hethal cells spread or cancer cells spread. You're not at an increased risk for recurrence as long as the appropriate operation was done. Next question. After a thyroidectomy, can your thyroid or any portion of it grow back? So if your thyroid was removed correctly, your thyroid is not growing back. So we see patients here all the time that say that they had a thyroidectomy and now they have this thyroid goiter. How is that possible? So it's possible because the thyroid actually was not completely removed. A nodule was maybe removed, or part of a lobe was removed, but not the whole thyroid was removed. And in those instances, yes, thyroid nodules can grow from the remaining thyroid tissue that should have been removed the first time. But if you have a right-sided thyroid lobectomy, you should not have regrowth of thyroid tissue on that right side. If you have the whole thyroid gland removed, no thyroid is growing back. So don't be fooled if surgeons or doctors have told you that in the past. If your thyroid has grown back, it's because the thyroid was never removed in the first place. So just some information for you to keep in the back of your mind. Next question. Can a goiter vary in size within months, getting smaller and larger? And can a small goiter still cause symptoms? So a goiter, it can change in size. You can have nodules that are cystic nodules where the fluid component of the nodules kind of changes. So that can make the goiter look bigger or feel bigger. And then maybe a month later that the fluid in that cyst is less than it was. And so you can feel changes in what the goiter looks like or feels like. And yeah, absolutely. If you have a small goiter, you can still have symptoms. So, your thyroid, it sits right on top of your windpipe and your esophagus, and we have small receptors there. And depending on the positioning of your nodules, if those receptors are being irritated, it can really feel like you have that you have to cough, or that you're feeling that you're choking. Even though your nodules aren't so large, you can certainly still have that sensation. And if you're having the sensation, that is a compressive symptom, which is an indication for thyroid surgery. So you don't need to have these large nodules to have surgery indicated. If it's bothering you, where it affects your quality of life, then I would recommend an operation. All right, so some more live questions that are coming in as we speak. Can thyroid cancer cells ever spread to the space between the vertebrae rather than lymph nodes? So yeah, aggressive thyroid cancers can have what we call soft tissue extension. So we like to talk, when we talk about thyroid cancer, to give you a better idea of what we see in the operating room. So thyroid cancer can have these little finger-like projections, and those finger-like projections make the planes or the tissues in the operating room very sticky. And so cancer can spread, into those soft tissues down where your spine is, into that soft tissue. Not necessarily, that's different than what if we're talking about, metastatic deposits in the actual spine. That's different. But, if we're just talking the neck area, kind of down into kind of what we call the prevertebral sheath, the posterior portion of your neck, thyroid cancer can spread into that soft tissue. Next question. I want to come see you for surgery, but I live in Ireland. What prior testing do you require before taking on a case? I am unsure of where to start. So if you're coming internationally, we want to make sure that you're traveling all the way over here and that, you really need an operation, right? We don't want you to come here and then us say, you don't need anything. Of course, if you wanted us to just evaluate you, we're happy to. But really, we want to make this as meaningful of a trip as possible for you. So, you definitely need an ultrasound so that we can see what's going on in your thyroid gland. That's the most minimal thing that you need. If you can have an ultrasound and a biopsy performed, that's really the two most important things. And then I can tell you, if you need to come here for surgery. Really, that's all we need. Everything else, if you need a CAT scan, blood work, everything else we can do here during your visit. But I would strongly encourage that if you think you need thyroid surgery, contact us through the website and make sure you have an ultrasound and a biopsy done. Go to thyroidcancer.com, fill out the form. I call all of our international and our out-of-state patients currently, so I would be the one calling you to go over your case and let you know how to come on over. I'm worried about becoming hypoparathyroid after surgery. How do you make sure the parathyroid glands are safe? So this is a great question. So, parathyroid, the parathyroid glands are a known risk to any thyroid surgery. Expert thyroid surgeons should only be doing your thyroid surgery. During the operation, we have to identify your parathyroid glands and we save them. So that is how we make sure that they're safe, is by identifying them. If we're doing a right-sided only operation or a left-sided only operation, we'll identify those two parathyroid glands and we'll save them. If we're doing a total thyroidectomy, all 4 parathyroid glands will be identified and saved. There are times when a parathyroid gland cannot be saved. The parathyroid glands and the thyroid share blood supply. So sometimes when we're trying to save the parathyroid gland can actually lose the blood supply. If that's the case, then we'll transplant that parathyroid gland back into a muscle in your neck, and it will actually form its own blood supply over the next couple months. So we want to try to save as many parathyroid glands as we can, so that you do not become hypoparathyroid after surgery. Now, acutely after surgery, even if all 4 parathyroid glands are saved, they can go into a little bit of what I call a shock after surgery. You may need some calcium and vitamin D supplementation temporarily. So what we'll do is we'll check your blood work in the recovery room. We'll also check your blood work the morning after surgery, and we'll let you know if you need calcium and vitamin D supplementation. We'll let you know what your regimen will be, and we'll follow you. So if you do need calcium and vitamin D supplementation, it'll be temporary for up to 4 weeks. But we don't expect any permanent hypoparathyroidism at all after our thyroid operations. So we'll follow you on a weekly basis with lab work, and until you're completely tapered off your calcium and vitamin D supplementation. Next live question. If someone has a multinodal goiter with nodules on both sides, would it ever make sense to remove only half? Would the other side keep growing and ultimately need to be removed? So this is a conversation, that we'll have when you come here. So if you have, let's say you have multiple nodules, and you have nodules on both sides of your thyroid gland. If your largest nodules, let's just say for conversation's sake, is on the right side, and you have just smaller nodules and less nodules on the left side, absolutely, we can try to save the left side of your thyroid gland because the majority of your symptoms are going to be coming from the right side. Is it possible that those left-sided nodules will grow in the future? It's possible. But if you look, let's say you're 50 years old and, you have 1 centimeter nodules on the left side, but 7 centimeter nodules on the right side. If you look at historically for the past, let's say 35 years, your nodules on the left side have only grown to, 1 to 2 centimeters. So it's reasonable if you want to try to save half your thyroid, and you're okay with the very small possibility of the need for a second operation in, let's say, 6, 7, 10 years, then absolutely. Then, you've saved half your thyroid, possibly the need for medication, and we can do that. If the idea of monitoring your nodules is not something that you want to do, or you absolutely do not want a second operation in the future, then we just take out your whole thyroid from the get-go. Or if the nodules on both your sides are large on both sides, then there's no reason, and I wouldn't recommend saving any portion of your thyroid gland. So it's certainly a conversation, that we have once you get here, when we do our own imaging. Nothing's set in stone. When you schedule an operation with us, if you're scheduled for a thyroid lobectomy, but then you come here and we do an evaluation, and we decide that you need more, then we just do whatever you need. So nothing's set in stone until we do our in-person evaluation with you. So this question I get a lot. Could a biopsy ever cause cancer to spread? So again, a lot of people are scared of this idea of seeding. So with thyroid cancer, and I'll speak only to thyroid cancer, a biopsy is not going to cause your thyroid cancer to spread. So if you have a thyroid nodule that's suspicious, if you have a lymph node that is suspicious, the standard of care is a fine needle aspiration biopsy. It's ultrasound guided. You absolutely should get it done by an expert, not someone that just does it every once in a while. But this is not going to, spread your thyroid cancer. It's actually going to help in the diagnostic process, the evaluation process, to determine the surgery that you need in order to cure the process. So this is actually our last question. So I will go over this last one with you guys. So if I have a biopsy done locally before coming to see you, will you do an ultrasound and biopsy also? Is it safe to do biopsies so close together? So if you have a biopsy done prior to coming to see us, there's no reason for us to repeat your biopsy, unless you want us to. But for the most part, we're not going to repeat your biopsy. You've had a biopsy done, a pathologist has looked at it, you have a diagnosis. However, we will always repeat any ultrasound. We always do our own ultrasound when you come in to see us. And the reason for that is that we don't want to miss anything. We also want to see everything for ourselves so that, we're going to be the ones doing the operation. We want to see what's going on in your neck. But more importantly, we just want to make sure that we're not missing anything. So, and we're also going to be looking at things that possibly other people haven't. So we're always going to be looking at the lymph nodes on the sides of your neck and the lymph nodes around your thyroid gland, where my guess is that, you haven't had that looked at before. So we don't always repeat the biopsy. We will do a biopsy on something that's surprising that we found that other people missed. But we will always do our own ultrasound. And it's certainly safe, if you need biopsies close together, if it needs to be done, it's not going to cause you any harm or any seeding. So I hope you guys enjoyed this live Q&A session. It was really fun for me. I love getting these questions. I love kind of educating you guys, because the more educated you are, you kind of feel like you have more power. So we're definitely going to do this again. If you have more questions, you can even send them in now. Keep an eye out for our next session. And hopefully I'll see you here at the center if you need us. Have a good day, guys.